who talked about the changing nature of critical care medicine, the gap in the need for critical care physicians over the next 10 years, and how that too is going to be a tremendous change that we need to embrace, that is quite expensive. And today we put that culminates with a presentation from our fairly new chair of OBGYN, who I'll introduce in a minute, who's going to talk to us about the Affordable Care Act and its implications. But it's Derby week, so I have to start with a few words about Derby. This is my third year in Louisville, and I'm always amazed at the tremendous energy generated during Derby, although I went to Derby the first year, and I'm happy to say I'll watch it on TV this year. But as you know, Derby started in 1875. That was the first Derby. By around the turn of the century, people who were owners of horses who wanted the Derby started sending them to the Preakness Estates in Baltimore and to the Belmont in New York. But it wasn't until the 1930s that a sports writer called Charles Hatton, and I didn't know this name, actually coined the term Triple Crown. And I remember as a child in the late 1960s watching on TV next to my father, and him explaining to me what the Triple Crown meant. Now remember, I'm from the little island of Puerto Rico. We have horses and pasofinos, but we didn't have the Triple Crown. So that was incredibly exciting. And to be on this town, my father always reminds me to ensure that we watch this at least from a distance. And so today there are many people around the world who remember important names. Aristides, the horse who won the first one in 1875. Exterminator in 1918. Majestic Prince in 1969. Secretariat 1973. And of course Animal Kingdom last year. In this auditorium, I want the people to remember other names. Haldane, Ricketts, Cooley, Thompson, Abraham. John Scott Haldane was born on this day in 1860. He was a Scottish physiologist who described the Haldane effect through experimentation on himself. He worked a lot on human respiration. He described that as you deoxygenate hemoglobin, it has a higher avidity for carbon dioxide. Howard Ricketts died on this day in 1910. He described the cause and the mode of transmission of rickets as well as typhus. And working in New Mexico in 1910, he described that a lice actually transmitted typhus. He got stricken by typhus and died that year at the age of 39. Denton Cooley, on this day, back in 1968, performed the first heart transplant at the Texas Heart Institute to a gentleman called Everett Thomas, who actually survived about 200 days after this heart transplant. Sir George Paget Thomson was born on this day in 1892. He was an English physicist who shared the Nobel Prize in 1937 for demonstrating that electrons actually undergo diffraction. And then Carl Abraham, who studied under Jung and also under Sigmund Freud and did a lot of work, among other pieces of work, about childhood sexual abuse and its impact on mental illness. So those are important names to us. And someday I will be also mentioning Dr. Sharmila Makhija is one of those names, who's professor and chairman of OBGYN and Women's Health at this organization. She obtained her MD in 1992 at UAB. From there to 1996, she was at this organization as a fellow in OBGYN. Then she was a fellow at Memorial Sloan Kettering Cancer Center. She was an assistant and associate professor at UAB, moved to Emory University, where she was division director in the same department, and in 2009 and 2011 obtained an executive MBA from the Goizeta Business School. So she's well trained in medicine as well as in business, and it's going to be incredibly helpful for this organization to move us forward in these difficult waters. But she's also very well known as a strong educator, a strong clinician, and a researcher. In 2009, she was awarded the Georgia Cancer Coalition Distinguished Cancer Clinician and Scientist Award. Since 2008, she's been named as the top 15 doctors in women's health care, and she currently holds the Donald Baxter Endowed Chair. I want to welcome to the stage Dr. Makhija, who has been a tremendous addition to our chair group at this organization. Thank you for being with us today.
Thank you. Well, thank you very much. I really appreciate the invitation. I did do my residency here many, many years ago. So it was interesting to come back and be the chairman of the department. And I owe, actually, I feel, my career to this university because it was here that I really was exposed to teachers that really cared. So it's really quite an honor to come back here and work. And thank you very much, Jesse, for inviting me here today. So I debated whether or not I would speak about the typical GYN oncology topic or go a little bit outside of the box. And one of the reasons that this actually came onto my radar was that I was sitting in business school in my econ class, and my professor said, "Oh, this bill just went through. Why don't you review it and give us a report at the end of the week?" Any idea of how big this, how many pages this is? Just guess. I hear 700? 2,500 pages. So what is the likelihood that those legislators actually read this? Probably pretty slim. But I did read it. I read pretty much every page. And I actually went and met with two gentlemen out of Emory that were on the committee with the president to come up with this bill, to come up with this potential law. And it was interesting getting their perspective on this because they said, you know, this isn't actually what we recommended. So I got their perspective. So I'm going to try to just show you the facts and then give you some of the commentary that I received from an audience like you, just to give you a perspective of what exactly this entails and how will this affect us. So I'd like this to be interactive, so please feel free to interrupt me if I'm not making any sense, because these are very different terms, and I think it's important for us as healthcare providers to really understand how this is going to impact us as a provider or even a receiver of healthcare. So we're going to look through the key components of it's changed its names many times, and you may have seen on the title before that, I had it listed as the bill's name, but it's changed now to the Patient Protection and Affordable Care Act, so I'll just call it the ACA. What I did was to compare it to other systems that were very similar to what we are proposing to do, and that was based on feedback on the two gentlemen out of Emory that were in the School of Public Health that were on that committee. So there's a little controversy of do you really want to compare it to these two countries, but they're the most similar. They're smaller, but it's interesting to see what they've done and the problems that they've had. And that's why I think it's important to kind of take it in perspective, just not exactly what they've said in the bill and now a law, but really compare it to a different country. So just to start off very simply, this is actually what this act says. The Patient Protection and Affordable Care Act aims to provide affordable quality health care for all Americans, and I underlined all because we'll look at how many this really affects, and reduce the growth in healthcare spending and for other purposes. I like that part. That's like when we were doing surgery, other indicated procedures. They have a little catch-all so that they can throw in whatever else they think it should be covering. So we're going to look at the actual act. We'll look at how do they propose to finance this law that's gone into effect compared to Germany and Switzerland. Look at the actual budget. It's one thing to propose financing, but let's look at the budget, and I'll just give you a little synopsis of some of the issues of how they budgeted for this, and then some of our thoughts. So why do we need this healthcare reform? Well, we have about 50 million uninsured, and remember that number, 50 million that are currently uninsured, and then I'm going to show you the number that this actually will affect. We spend the highest percentage of GDP on healthcare. It's actually gone up to about 17% now. But we consistently rank lowest with the WHO ranking on certain health indicators, including life expectancy and infant mortality. Those are the two parameters that we really look at when we're comparing countries. So why did I also throw in Germany? Well, we talk about socialism and that this is more of a socialistic type of healthcare reform. It's not technically socialism. It's social insurance, and that's come from the Chancellor von Bismarck. So that's why you might hear this called as a Bismarckian ideal or Bismarckian type model. He had variations of what he thought social insurance should be, but in this particular case, he felt that equivocated to health care for all, based on your social class. So that's where you might hear, I just wanted to give you a little bit of a background. That's a very, very light way of touching into it. We could spend hours talking about the von Bismarckian model, but that's basically the premise for this. And under his guidance, he created the nation states in Germany that really talked about the mandatory health care insurance. So let's look at this, and I tell my residents and students and faculty, don't ever give a presentation like this. It's got a lot of words on there, a lot of sentences, busy slides, but I wanted to make a point with this of showing you how detailed they have written it and how difficult it is to kind of sort through it. So to start off with, we'll start off with the insurance companies. These are the parameters for the insurance companies in the Act. They'll be prohibited from refusing coverage for any pre-existing condition. One of the pre-existing conditions that affects my department is pregnancy. That's actually considered a pre-existing condition. So you'll be surprised that that can actually be a problem with many insurance companies. They have to abide by a yearly cap on how much they can charge for out-of-pocket expenses. So far so good, sounds good. They have to fully cover without charge regular checkups and tests for preventive care, so no cost sharing, no co-payments. Keep that in mind, because if they balk on this, maybe it's in the budget, and I'll show you that it's actually not in the budget. They'll be prohibited from dropping or watering down insurance coverage for those who are very ill. So as an oncologist, I see this all the time. They'll all of a sudden say, hey, you know, we've spent this much money on you, we're going to have to start slowing this down, especially when we're looking at hospice care. So this would actually protect patients from that. They'll be prevented from placing an annual or lifetime cap on coverage. This, you know, has already gone into effect, that children will continue to be eligible for family coverage through the age of 26. You'll also see that the insurance companies will have to renew any policy as long as they pay the premium in full. And that's a key point. If it's late by 1 day, you know now that they can cut that off. There are stipulations, and this is also under a lot of controversy with the insurance companies, of when they can consider this payment late. Number 8 is a very important concept, and I want to spend a little bit of time talking about that, because that is what you see in the news and the media with the lawsuits and even the Supreme Court debate. Does anybody know what a health insurance exchange is? So that's concerning, right? Because that's really the basis of this particular law. And it's the basis of the controversy. So a health insurance exchange is, and what they're proposing is the state becomes that exchange program. Much like what you have here, when you come to work at U of L, you have an option of Aetna or Blue Cross. It's the same way. The state will be able to negotiate a good rate with all these insurance companies and offer an individual the ability to have a good premium. So it's very similar to that. The problem is that in number 10, when this becomes enacted in 2014, the federal government will help these states cover the cost of this insurance exchange. But as soon as 2015 hits, the states have to take that over. So what do you think that means? Do you think that Connecticut is going to be equal to Mississippi? Probably not, right? Because if you look at the healthcare statistics, you know diabetes is a bigger problem in the southern states. You've got more obesity-related issues. It's going to cost more for our southern states to take care of patients than it is the northern states. That's already been reviewed and looked at. So that's part of the controversy, is states are saying that's not really fair. We shouldn't have to take on that burden. You know, we can't control who's in our state. We can't afford this. And thus, there's been 28 states now that have filed suit to the federal government saying it's unconstitutional. So that's something, if you take anything home today, understand what this health insurance exchange means and what the impact is to your state, because states don't have the money to cover this. So I think that we all went into medicine to help patients and to help people. We want health care for everyone, but how much is it going to cost us? And how are they going to fund this? Is this delivery plan plausible? And does our current framework and structure of the U.S. government really lend itself to being able to do this? So the Congressional Budgetary Office, or the CBO, estimates that this reform will cost almost $1 trillion over the next 10 years. But they also predict that it will reduce the deficit by about $140 billion over the first 10 years and ultimately $1.2 trillion over the next 10 years. When I talked to the gentleman at Emory, they said that's really not accurate. You know, that's on in a very ideal situation, but they're actually predicting it'll cost more than that. So if you're going to fund anything, or if you need to get something started, right, you have to at least, you either have to tax or fine, or you got to cut costs. So let's see how they're proposing, and I'll just briefly touch on some of their concepts. You know, recently that we talked about the Medicare payroll tax, and that was all over the news, that was really used to expand to include a tax on unearned income. So that's one way that they're figuring out they can use the money to pay for this law. In 2018, insurance companies will be taxed at 40% for these Cadillac plans, and these are for patients that don't want to go in an exchange program and want to have their own, you know, very boutique type of insurance plan, or a first tier type of insurance plan. If insurance companies allow that, then they will be fined 40% of that cost. Then there's also a new Medicare tax on individuals earning over $200,000 that's supposedly going to go into effect next year as well to bring in more money. You already know about the 10% excise tax on indoor tanning salons, the annual fee on manufacturers of medical devices and prescription drugs, and there's also a medical tax deduction threshold that will be raised in order to tax and gain more money. Now, when we talk about fines, this is the important concept number 2. So the first one was health insurance exchange, and why are the states, filing suit? Number 1 on this is the reason why the Supreme Court is now deliberating over this Affordable Care Act. In 2014, this individual mandate will be enacted. So every American will have to have health insurance or pay about a $700 fine. Employers with more than 50 employees will have to provide health insurance or pay a fine. Anybody have an idea of why the Supreme Court is deliberating number 1? So they feel that that's unconstitutional, okay, to force someone to take or to mandate a health insurance, to mandate or force someone to take health insurance. And I'm no lawyer, but basically what they're saying is it impacts interstate commerce. Now that sounds like that's very, very much removed from what we're doing every day, right? Taking care of patients, person just needs to have health care insurance. What that means is if you're forcing someone to take it and they don't, and you fine them, there are 2 sides to that. If you're forcing them and they don't do it, by not acting, by that person not getting health insurance, are they not actually creating more burden on everyone else that has to pay now to compensate for their care? And then you're redistributing how much things cost all across. And the flip side is also argue that if you do make them take it and they do pay for it, are you now impacting the cost of care? So there are both sides that are complaining about it. What's even interesting, if you take it one step further and you say that, okay, we're going to remove number 1, we're not going to mandate it, and there's something called severability. So you remove that part of the law out, and the rest of the law should stand steady. The problem is, if you take this part out, the rest of the law will just fall apart. So that is what is under debate right now with the Supreme Court. It'll be interesting to see what they decide, especially since it's an election year, because if you look at the makeup of the Supreme Court, you've got 4 liberals, 4 conservatives, and then you've got Justice Kennedy that sits right in the middle and who's going to decide, basically. So it'll be very interesting to see. I don't know. I honestly can't say that I think that they'll decide before the election, but if there's anything you should take home from this, is that that is the reason why this is being debated and why this is felt to be unconstitutional. So moving on, if you can't tax and you can't fine, then you need to cut costs somewhere. So these are just some of the things that they feel that by spending money on this Health Care Act, that you will actually reduce the ER visits for the 24 million Americans that don't have insurance, that are, visiting the ER and using that as their primary care. That's debated because I don't think that that really, if you're going to move those people now into your infrastructure, we really can't accommodate those patients. So is there now an added cost of building more facilities? So that's probably a wash, but that's what they're banking on, is that you're going to move them out of the ER, put them into primary care specialties to be seen, and that's really heavily debated as well. So let's look at Germany and Switzerland and see what did they do and what did they do right and what did they do wrong. So in Germany you have 16 state governments, so very similar to what we have, and you have the federal government as the governing body. They have something called a sickness funds that helps to support the healthcare costs. It's also financed by a 13.5% income tax, and they have what's called a high-risk pool assessment. So they put patients into a low-risk and a high-risk assessment, and then move the ones that are more of the high-risk or more costly into being seen by certain doctors that are actually better at taking care of them and more cost-efficient. What are the problems? Is they're having to increase the income tax to cover the costs. And these so-called first-class physicians have now moved to the private sector, so they're having now a two-tier system in order to survive. The percentage of their GDP spent on healthcare is about 10%, and you can see their premiums are about $750 a month, and they have co-payments of about $15. In Switzerland, they have what are called cantons, so again, very much like states. They also have a federal government as a governing body. They also have sickness funds that help to pay. They're financed by cost sharing, and they also have a high-risk pool assessment. What's interesting is that they are considered one of the most regressive healthcare systems. They've evolved into this. They have difficulty collecting fines, so that's a key point to remember, because here we are saying that we're going to, pay for our law, this healthcare reform, by fining. They can't collect fines. So do we spend more money trying to collect these fines and then you end up having a wash? They're having a problem with this. So they're actually going to be increasing their per capita premium, and they're moving towards an HMO type system. They spend about 11% of their GDP on healthcare. You can see their premiums are very similar to Germany. If you look at this, and I know this is a busy slide, but if you look at the WHO performance rank, that's that first highlighted, they're pretty low compared to Germany and Switzerland. We have a higher population, right? A bigger population than these other two countries. Our population growth rate is far more than theirs. This is a key thing that I want you to watch. They are having problems with just, having a smaller population. Their main top causes of death are cardiovascular disease and cancer. We have the same, but we have diabetes. You know, being in primary care, this is very costly to take care of. I want you to remember that when we look at the budget, as how is this being addressed in our budget? And this is what we talked about before with the GDP. You can see that we have less physicians per 1,000 inhabitants compared to these other countries that are smaller. And this is also very important. I know it's at the very bottom. The percentage of population age 65 receiving formal help at home. We have almost 16% compared to with Germany is about 10%. But 16%, again, remember this when I show you in the budget how we're addressing home health care. So remember at the beginning it said this was going to cover care for all Americans. We have 50 million that are uninsured. By the end of this 10-year proposal, we're really only going to be covering 32 million. So really, we're not covering everyone. They boast about preventive care. We really have to focus on preventive care. If you look at this, and this is now in billions of dollars, just look at even tobacco cessation programs, pretty much nil. They're not putting any money. Look how little they're putting on nursing home visitation services. Very little. Required coverages, I mean, 10 billion. Okay, but that's not really a lot compared to everything else that you see. Home health, it's actually negative. They've actually removed how much money they're going to put in to home health. And diabetes, just having simple diabetes educators as providers, nothing. No money for that. So have you wondered why Romney hasn't talked about his Romney Care that he developed in Massachusetts? I mean, if it was working, I think he'd be talking about it every time at the debate. What's interesting is it's very similar to what we are proposing to do on a national scale. It was very hard to get some of this information because they don't publicize this much. Again, I had to go through the folks at Emory to really be able to extract a lot of this information. But I thought this would be interesting because, okay, we talk about Germany and Switzerland, but it's different here, and we actually, I think it'll be worse, right, because we have a more diverse population than those two countries. But, well, I think maybe we could still do it. Well, let's see what they did in Massachusetts. So they actually have the law. They, have the health care reform law that was passed in 2006. They have what's called Commonwealth Care. That's their insurance exchange. So they have 5 health care plans that are involved with that. Again, very good. They're directing their focus on those patients that are low income, unemployed, subsidized according to their income. So far so good. Monthly payments, pretty reasonable. They're funded by $700 million a year from this uncompensated care pool, which is comprised of insurance companies, hospitals, tax revenue, plus another $385 million a year from Medicaid. Employers have to cover about only a third of their health care plan or pay a fine of about $300. And individuals are penalized with paying half of the yearly premium if they don't get health insurance. Any guesses on whether it worked or not? Probably not, right, if we didn't hear about it during the debates. So, okay, so they decreased the uninsured from 6% to 4%. They projected to cover about 170,000 people with a cost of $600 million. They actually covered more, 342,000, actually costed $1.35 billion. The short-term funding gap was $100 million, and they had to get a 3-year agreement with the government, which you didn't hear about in the news, of about a $1.5 billion loan just to cover costs. Their healthcare costs are rising at a rate of 10% right now. They're in a deficit of $1.3 billion, and this is very important, this last line. The rate of new business startups has decreased by 16%. They've all moved to Connecticut and to Vermont to start their companies because small business owners can't afford to pay for health insurance for their employees. So, again, we all went into healthcare to help people. We want to help patients. We want everybody to get healthcare, but we really have to look at this in a very logical way instead of being too emotional about it. We really have to look at how do we fund this, or do we do this in steps? Because I think to just throw in this pool of another $32 million into our current system that's already pretty overextended, I think is going to be difficult. So you're going from one swing of the pendulum of nobody really paying attention to now having the government really control it. I think we need to be somewhere in the middle, but we've got to make the smaller steps of looking at what's happened in Massachusetts, what's happened in these other countries. So I'm not cynical by nature, but I thought, well, when this was going through, what were the lobbyist groups saying? So I'm not the AMA I think is fine, but I think the AMA is like us. I mean, we want people to be taken care of. We want the right thing to happen, but sometimes we don't really look at how that's going to affect us. So when this was getting passed or being discussed with the lobbyist groups, the AMA, you can tell, probably had the weakest lobbyist group, because they said, sure, this looks great, but could you kindly maybe, freeze the Medicare cuts? And they said no. Eventually that has happened, but basically said no, and the AMA said, okay. The trial lawyers, the PAC lobbyist group, said, okay, we'll support you, but you can't touch or lower fees, can't put caps and damages. They said, okay, fine. Pharma said, sure, we'll support this, we'll give you $80 billion. But then when the government changed the patent protection, they said, forget it, we're pulling out. So just to get you a balanced view of, yes, there's the ideal view of taking care of everyone. There's even the hardcore looking at the finances. But then you've got the politics that are involved with this, and that's just a touch of it. There is a lot more to this than just, I just wanted to give you a flavor of it. Some of the things that I've heard when I've given this talk to other groups, and that's why I do want you to tell me your thoughts at the end. We really should look at, if we're going to have to take care of more patients in a very fragile system that we have now, we've got to look at the fact that we need probably tort reform addressed, because I think that there's going to be, if you're going to cut down costs, where do you think they're also going to look at costs? They're going to look at, the insurance companies are having to take on a lot of this burden. Where do you think they're going to cut it? They're going to cut it with our reimbursements, right? So you're going to see that we're going to get paid probably less, and that we're going to see more patients, more complicated patients. Tort reform really should be something that we need to start talking about. Again, not that we went into this for money, but you have to look at the cost of educating doctors, the loans that we have. There's no discussion and nothing in the budget for subsidies for medical education. Germany addressed this and did it, but there's no discussion about that because, frankly, why are you going to have a $200,000 loan to make $80,000 when you can go into, Wall Street or somewhere else and make more money? We've got to address the educational costs of educating more physicians. About the lawsuits with the 28 states that have filed suit. That'll be very interesting to see, and I think whatever the Supreme Court decides will really decide on whether or not this act is going to go through and truly become enacted in 2014. And you really need to hone in on what the actual cap is for the insurance companies. It's kind of just said in a very nonchalant, we'll cap it, but there is no cap that's placed because that's being really heavily debated by the insurance companies. So are we going to have to create an office to start collecting these fines, and how much is that going to cost us to start doing that? I think that's going to be a big problem, as we've seen in the other countries. Somebody has thrown out a flat percentage income tax rate. I think that'll be a whole nother political discussion. So, that's something that we have to consider. If we're going to do this, do we need to consider doing a flat income tax rate? And the final one at the very bottom, really, we have to look at how this is going to impact small businesses. Right now, businesses are moving to Mexico. They're moving out because they're afraid of how are they going to actually pay for their employees and their health insurance. Or we can all just go to China and have our health care. So with that, I'll end it, and I'm happy to answer any questions that you have. Thank you.
So, Sharmila, one of the questions that people talk about regarding recommendations is is it possible to limit coverage to very basic primary care and leave the rest untouched as a first step? Now, as a doctor, it's very difficult in the office to say, I can do this, but I can't do the flu shot, and I can do that, but I can't give you the insulin. But there are ways to separate the two. We pay for this, we don't pay for that, that at least primary care is provided, and see where that takes us, and then move to the next step. What do you think about that?
Yeah, I think that's actually what we have. When I discussed it with the colleagues at Emory, they had proposed that very same thing of just step by step. Start with the basics and keep building on that as we do well with that part and we're getting basic care out. then are we collecting enough money to finance this? Are we now being able to expand our services? I think this is where the politics comes into play. It's very strong to say it's for every American is getting health insurance. Done deal. It's very simple. So I think it was the wow factor of, oh, we're going to actually be able to do it. But you're absolutely right. We even do that with our patients, right? Okay, here's your overall health situation. Here's what we need to fix right now. This is what we're going to work on long term. And we do that every day. Mm-hmm. But I think that what's interesting is there was not one doctor on that panel that helped to write this. I think they had a dean of a medical school, but that was not primary care and not practicing. So that makes a difference, because if you're a practicing physician, you know how hard it is to take care of 30 patients in a clinic, and now you're going to add more patients to my clinic.
The other thing that struck me about your numbers was the tremendous decrease we have compared to the other two countries about doctors per
That's right.
population. And yet there's nothing discussed about physician coverage and how many doctors we can train, or even increasing residency amounts in hospitals and things like that.
Well, and so if you looked at it, even Kentucky, we're predicting a shortage in the next 5 years of covering patients even in this state. That was brought up as far as just even bringing in more doctors to cover these 32 million additional patients, not even looking at what's already being predicted that we're going to have a shortage at our current state. There's been talk about adding more slots to medical schools. Do you know why they haven't added more seats? It's actually not even money. It's the number of chairs that are in the auditorium. That's how they determine it. It's very interesting. So now do you build? Do you have double classes? I mean, so we're almost on a very basic level where we're just going to have to wake up and either build more medical schools, which you do see some popping up now, but I don't know, I can't remember what he had said, how much that we were, how many medical schools we'd have to build, but it was pretty large. It was like 20 more to maybe take care of our current shortage, not taking into account these 32 million.
Questions? Jeff?
So two things. One, if you build more medical schools and have more medical students, but you don't fund more residency slots, we're going to train people to do things. And then why don't the usual economic forces of supply and demand work in healthcare? If we're in shortage, we should be paid more.
That's right.
If you can't find the top Mercedes because there are only 1% of them that are made in terms of cars, it costs you an arm and a leg to buy it. And yet, on the other hand, we are, in medicine, we have traditionally allowed ourselves to be manipulated by government and by insurance companies.
Right.
We're in rare supply, we're becoming more rare supply, and yet those usual forces of economics don't seem to apply to us.
No, it's absolutely true.
Can you summarize that on the microphone for those who are...
So the question is, if we even increase medical schools and more doctors, our medical students, are we actually then addressing the number of residency slots? So that's problem number one. Problem number two is supply and demand. If you're going to need more of us and there's not enough of us, we should actually get compensated more and not less if we're adding in more patients. The first one is pretty simple. The federal government has not allocated, residents are paid by it's federal subsidies. They have not addressed that. And when that was brought up back to this committee, we'll deal with it later. It was just not on the radar. The second, with supply and demand, it's our fault as doctors. Again, the AMA, not to blame them, but if we had the same lobbyist group as the PAC lawyers, the PAC lobbyist group, trial lawyers, I think we'd be in a different situation. We're not programmed to think like that, and I think that there's a different involvement now with doctors of being more aware. I wasn't probably aware of much of this until I hit business school, or you start... if you're running a division, you start to look at the finances. But if you look at the overall impact, we can sit down and say, hey, we're not going to see these patients anymore. I think we feel bad if we say that. And I think I think they're banking on our emotional response. So we have to be able to stand up and say, no, this is not the way it's going to be. If you want us to take care of these patients, we've got to be compensated better. We have to renegotiate with the insurance companies. And that's a tough job to do. That's a tough job to do, but I think that is what we have to do.
I guess two things. In one side you're saying, boy, we need a stepwise approach. From my perspective, this is a step, and I agree that it doesn't cover quite a bit. There's a lot going on.
Right.
The reality is, from my perspective, and I know several other in the department, we need a single payer system. And that wasn't even on the table either when you're talking,
Right.
And so, I mean, it is a very charged political debate, and it's going to take us some time to get there. And, the piece that you just last said about us as physicians refusing to see patients, there's no way I'll do that.
Right.
Because I am ethical.
Right.
And that's to my, to your response, the reason, and you're right, they do bank on it, and they should. We are going to see the patients and take care of them, because that is our job, and that is why we went into this. And it is true that we do need to step up and figure out how do we advocate to help make change, but it's not going to be able to stand up from my perspective. We're not going to stand up as a group to the insurance companies and say, no way, we're not going to see these patients.
But
I hope we don't.
And I agree. I mean, I hear you. But if you step back and look at it, not to be cold about, we are a business. We're in the business of taking care of patients. It's a fine line, right? Because it banks on our emotional aspect and why we went into this. I mean, not everybody can go into medicine, right? Because we're going to stay till 10 o'clock at night and take care of that patient that has no money because we know it's the right thing to do and we care about them. But we also have to look at the balance. How do we support taking care of those patients in an overall system to sustain it?
Lori?
I just had a question about how removing the public option from the initial bill impacted the newer version and what your thoughts are on how the bill was in its original form.
Yeah, so how did that impact of the public option being removed? How did it change the bill? So I have my opinion and it's just my opinion, but I think it really didn't have much of an impact because I think they never really planned on doing it. I think they needed to do that politically and have that out there. And the insurance companies really hated it. And again, the players in this are the insurance companies and the doctors. And now the federal government is kind of overseeing that. And like you said, I mean, who's more powerful? The insurance companies or us, unfortunately. And so that was why it was thrown out. That's my opinion, but I don't know what's fact.
Canada is a single payer system, but it's a state and national hybrid system.
Right.
So some parts of Canada are physicians are much better compensated than other parts of Canada. And you have large, high natural resource wealth or something like that in the province. You have much better rates of physicians than you do
Right.
in poor areas. So, I mean, that sounds almost like part of what we would be dealing
That's
with
right.
in these situations as it seems.
Yeah, it's interesting. They didn't really.
Summarize
Okay,
Canada.
so the Canada situation where their provinces, some that are more wealthy, are able to have more specialist physicians compared to the provinces that don't have a lot of money, and that's similar to what we're going to see with the insurance exchanges with our own states. That's exactly what's going to happen here, I think. And it's interesting when you bring up Canada, they don't talk about it. They won't compare to Canada, and I really don't know why, because it's probably more similar what we're going to see than if you're looking at Germany and Switzerland, which is what they use as a direct comparison initially to create it. They ignored the problems because they thought, well, we can take care of those. But that's one of the arguments with the lawsuits that have been filed, is look at what has happened to Canada. Well, look at even what's happened to Massachusetts, right? It's because what's going to happen, all those businesses move out. Now you become a state that can't sustain it. So that's why the state says, if you're going to make us do it, then you're going to have to provide support because we're going to be in the same situation as Canada. That's right. If you want it for all Americans and even, it's going to have to be even across the states. Hi.
Part of my first question is already answered.
Okay.
I'll add here, Canadian pay more tax at 2 levels, provincial government and federal. They pay 2 types of taxes. But ultimately, the rich people, they always come down to this to get sophisticated.
Right.
Results.
Right.
My question is, even in the difficult times, cost of companies, they keep filing for bankruptcy because they can't sustain it. But insurance company, you have hardly heard anything.
That's true.
On that. They never file bankruptcy because they are flourishing. So what is it? Are we in a deep mess that we are being controlled by the insurance company to our medical system?
So the question is, I'll try to summarize. You see that companies that are filing bankruptcy, you see those, but you don't see the insurance companies filing bankruptcy. And really I guess your question is really, why is it that they're being able to dictate the care? Unfortunately, just to give you perspective, I think pharmaceutical companies get a little bit of a bad rap because they're claimed to charge so much and they make all this money, but they actually put the money back into R&D for the most part because very few of those drugs can make it big and get a patent. Insurance companies, I don't see, they get the money, but I don't see where it's going back in. So I think the argument was, look, you're making this money, you need to now participate in helping with the care for the people in this country. I don't even know what that conversation was like because I imagine it was, hey, we're a business, we're the middleman, we're the exchange, right? We're making sure you get care. But you're right, I mean, that is a problem because they're looking at themselves as a business and they're just in the business of making sure they cover the costs if they have to, but within a certain guidelines. And in this act, those guidelines are very loose. Yeah, you have to have a cap. Well, what is that cap? So that's still what's being debated.
Two things that they didn't address is in Europe there's a much higher percentage of primary care versus specialists here. So that's not addressed either way, either in the payment system or even in the budget. The second thing is that I can't see how this would work because the way we pay hospitals, there's no incentive to cut costs. Hospitals don't want you to order less CAT scans because they make money on them. Physicians don't want to do fewer CAPs because they make money on them. I'm not trying to cry off, sorry. But, we get paid to do things, and sometimes that influences your judgment, wrongly or rightly.
Sure.
And so, I don't see that being addressed at all.
So the question is how
When you summarize that, leave one of the words out.
Okay. The question is how do we address how we're getting compensated, right? And how is this going, European countries are looking more at the primary care. We have specialists, the compensation that we have of doing procedures. I didn't go into the details about how we're going to be reimbursed later, which will be quality-based initiatives, which we're already doing. It's interesting, I had to go up in January to take this value-based healthcare delivery at the Harvard Business School with Michael Porter, who's like the big guy with strategy planning. We're actually going to be teaching this at the business school here, and it looks at quality-based care. Now, we always think that we have quality-based care, but it's going to be directed at that very point. Not looking at the procedure costs, not looking at all of that, but what are the outcomes of a patient? Which is a little unfair because if you're a specialist and you're in a university system, you're going to get the ones that are sicker, but you're going to have to adjust for that. But you're going to get reimbursed based on the outcome of a patient, not, that you ordered 20 of these tests. But you're right. How's the hospital going to sustain itself when we're going to it's less likely that we're going to order as many tests because we're going to get dinged if we're ordering too many tests. So it's not addressed. It's not addressed at all. But it's interesting because Cleveland Clinic has moved in this direction and made each of their sections institutes, so they're freestanding. They actually shipped OB out to the community, which it should be. It shouldn't be in the downtown. I mean, that's just my opinion for for that situation that they have, out to where patients are delivering, where the community is. And the specialists are downtown, and they're in these institutes. And it's interesting, I think it's actually the Cardiology Institute that a radiologist runs it. So it's interesting. Like, they have a very different, not to say that you would be biased, not to pick on any cardiologists. I mean, I have those in my family too. It's to balance the perspective of what we're used to ordering and focusing on, and having someone else lead the team that looks at it from a different perspective, that doesn't have anything to gain. So they're trying a different situation. MD Anderson has moved to that situation too with cancer care. So there's a lot of groups now that are looking ahead, like you're thinking, how are we going to get reimbursed, and its outcome? Do we have good parameters for outcome measurements? Not really. Who's to say that we have to look at somebody getting readmitted? I mean, so they didn't take their medicine. Is that my fault that they didn't take their medicine? So, there's a lot of other layers of issues. And like you alluded to, I see patients all the time from Canada when I was at Emory, because they'd fly down because they didn't want to wait 5 months for their endometrial cancer surgery because they were in a low risk category. But if you got cancer, you want that done. They flew in, paid cash, they were done. So we're going to see a lot of involvement of how patients are going to move out to other systems.
Last question.
At the 100-foot level, do you think this will be an advantage or disadvantage for ULP?
Wow, I'm not even touching that one.
Next to last question.
Is this an advantage or a disadvantage for ULP? I don't know, Jesse, you answer that. You've been here longer.
Yeah, only a year later. No, go ahead. Come up here.
Technically, medicine and OB have not moved into ULP, so I don't know. How about that? I'll just answer that I don't know. I don't know. I mean, I think moving into ULP will be good, because I think that we look at being able to negotiate it with a larger group with insurance companies and get better rates and things like that, but I don't know. It's a fair question. What do you think? How about that? I'll throw it back on you.
We may get more patients that have insurance. We do have a lot of uninsured patients right now, but then we have a lot of patients who then would have insurance that they could take to other providers. So I'm not sure.
Yeah.
Thank you. Let me leave you with two comments from my standpoint. I will not discuss ULP. One is that I think that even though physicians by nature are not interested in politics, or at least not interested in being very open and vocal about politics, and I understand the reasons why. One of the reasons why there's a clear divide between the understanding of what academic medicine is in academic centers and the community understanding of what we do is that we don't do a good job at communication. If you're not interested in getting into this debate, if you're not interested in being the one figuring out budgets and things like that, I encourage you to be the one to inform your family, colleagues, and friends about what is it that you do in academia. What does it take to train a physician? How much time does it take somebody to bring a new drug to the market? What effort does it take for people to sit around to figure out how do you appropriately treat an insulin-dependent diabetic? That information is not out there. As this process moves forward, the bottom line will be about money. And we will perceive as the rich people on the 1% who are just asking for more and fighting for more money. Without that information, and without us being the ones providing that information, that debate will be lopsided. The second point I want to make is that we're going to have to change expectations for everybody, and for us as patients as well. Well, we're talking about the 50 million Americans who don't have insurance. There are people spending $50 million in the care of a horse who's going to play and run on Saturday. Now, I understand that. But at some point, we're going to have to sit down and reevaluate our priorities. And I will leave you with that message. But then I will thank Dr. Sharmila. This is no, this is for your faculty. No, this is for you.
That's good.
This is called the Derby Grand Rounds.
Oh.
It's been a tradition for a while, and we made it into a tradition that has a bat because the Slugger Museum and all that. And this is for you as a 2012
Derby Ground Round
Oh,
speaker.
thank you.
And we hope that you keep it as an example that we are your colleagues, welcoming you to this organization, and we appreciate very much what you did today, what you do for our patients day in and day out.
Thank you so much.
We've been debating what to do with